Okay, everyone. Can I just first of all welcome you all to what is one of the most spectacular venues that I think we've ever been to, the Bridgewater Hall, in the lovely sunny city of Manchester. And as many people said to me earlier on, it's not always like this. And then someone else said, but yes, it is, so I don't know. But it's, wonderful city, wonderful venue. Thank you. This is the ITPSA Support Association's 30th anniversary this year. And as many of you will know, it was started back in 1995 by a very formidable lady called Shirley Watson, MBE. And Shirley ran the organisation for many years until she handed over the reins to myself and Adrian, best part of 10 years ago now. But it's been going really well. It's gone from strength to strength, building on the work that, the foundations that Shirley laid. And we're so pleased that we've got to the 30th anniversary. Today's patient conference is all about you, the patients. There will be opportunities to ask questions at the end of each talk, hopefully if we've got the time. But in any event, we do have a Q&A right at the end of the session, which will be chaired by Professor Adrian Newland, our Chair of Trustees. And that would be another opportunity to ask questions. We will have a couple of roving mics going around as well. So I'd now like to just ask Professor Newland to come up and say a few words, as it is our 30th anniversary as well, and introduce the next speaker. Thank you.
Yes, welcome everybody, and thanks for making it to sunny Manchester so early on a Saturday morning. When looking at the weather, you actually want to be anywhere but in the bowels of Bridgewater Hall. But I think you'll agree we've got a very exciting programme today that's very much directed by feedback from you, the patients, over the years, looking at some of the aspects of management that we know you're interested in because you told us. And I think after lunch we've got a particularly interesting session looking at the psychological support, looking at quality of life, looking at what the clinical nurse specialists have to offer. And that's been one of the great developments over the last small number of years, is the spread of clinical nurse specialists, which I'm sure many of you find are a great first port of call when you require just a little bit of advice or a little bit of help or contact at an odd time. And I'm very pleased to say that the clinical nurse specialist group has become affiliated with the association very recently, and they'll be on our board and will also again direct what we want to do. And I think that's a great development. We're going to have the first session, the first talk on the unmet need in ITP, which I know is something, again, you're very interested in, and then we'll be looking at how we develop that later. We have the breakout sessions early, and we decided to have them early because it means you can get to talk to each other. And the adult session will be in this room. The other two sessions are somewhere else, but there will be people directing you to those. As it's our 30th anniversary, Mervyn wants to do a big picture at the end. We've got a large banner, and we want you all standing there, so you'll be recorded for immortality there, and we'll highlight it on our YouTube page, so your children's children will be able to see it in years to come, to show that yes, you're in Manchester on one of the few sunny days Manchester has. So we'll have that. The only other issue is all these things tend to drag on a little bit and get later, but we have to finish dead on 5 o'clock because they have some grand session here with a VIP that we're not supposed to know about, but if you talk to me afterwards, I'll just let you know who it is. So I've already gained 5 minutes for us here. So without any undue delay, we'll ask Professor David Kuter, who's been a very staunch supporter of the association over the years. We drag him back time and time again, and he agrees without moaning. Looking at some of the developments in the States at the moment, we're rather hoping that he may stay one of these times, and I suspect over the next 4 years he may want to. Either that, or he'll go to Harvard. Thank you very much. David.
On behalf of President Trump, thank you for inviting me here. I promised Adrian I wouldn't sing happy 30th birthday, but it's a delight to come back and see so many familiar faces. Adrian gave me a topic which I have no idea what I'm going to do with it. It's about the unmet medical needs in ITP, and there are many. So I'll start by just saying these are my disclosures. I work with many different groups to develop new treatments for ITP. And I'll start with an interesting discussion about the history of ITP, which we talked about before, which is this chap, Robert Willen, who published a book, and this is called On Cutaneous Diseases. This book is actually in our library at our hospital when I photograph this, and he's this very cherubic Yorkshireman here who looks very happy. And he published this book where he describes skin diseases, and he described this stuff called purpura simplex, which many of you can recall are petechiae. He then described these things, which he called purpura hemorrhagica, which are ecchymoses or purpura that you many have seen. And then he went on to discuss ITP and what it's like, and this is how he starts our unmet medical needs. He says, purpura hemorrhagica occurs at every period in life and chiefly affects persons, and don't hit me for this, of a weak and delicate habit. Women and boys appear to be the most liable to it. In the latter, the hemorrhage usually takes place from the nose. Then he goes on to say the causes of ITP: a sedentary mode of life, poor diet, impure air, anxiety of mind, are the usual exciting causes of this disease. And then he goes on to describe how this is treated. And this is very apt for many of us here. In the treatment of this disease, we should recommend moderate exercise in the open air, a generous diet, and the free use of wine. A stuff called Peruvian bark, which I think is sort of like papaya leaf these days, and then vitriolic acid, which we haven't used in decades. And then here's the important bottom line here. Without air, exercise, and easy mind, the effect of medicines is very uncertain. And I think right now in ITP, the effects of many medicines is certain. And I think right now what I want to do is just discuss with you for the next 15, 20 minutes what I think are the things we don't know about ITP. So we don't know what causes ITP. I mean, I think right now many of you who have ITP are sitting here saying, well, I don't know why I got this. You know, the gods have singled me out to have this disease. I think the problem we face is that we think we know things about ITP. This is an ancient experiment. Many of you know this is a guy named Bill Harrington, and he took plasma or whole blood from patients with ITP and injected it into himself. And his platelet count plummeted to very low levels, and he then described that there's something in the blood which we now know to be an antibody that causes ITP. So we know a bit about IT being immune-mediated, and that's one statement of fact. And this antibody does a couple of things. It makes your platelets be destroyed in the circulation, but it also prevents your bone marrow from making new platelets. And the way to think about what's happening in your body as an ITP patient is something like this. Here's a cell in your bone marrow called a megakaryocyte. I love these large terms, but the megakaryocyte is in your bone marrows and it makes your platelets. And basically what's happening in many of you with ITP is antibodies are coming along attacking this cell. Things called lymphocytes, which are another immune cell, are coming along and attacking this megakaryocyte. And this cell is dying, a thing called apoptosis, and it doesn't make platelets. So in part of your ITP is you don't make platelets. In addition, you've got this yellow arrow pointing to a platelet. This platelet's been coated like an M&M with antibodies that say, destroy me. And there's the bigger cell there, which also has a name that begins with M, but this is called a macrophage. This chews up cells, and the macrophage is shown here chewing up platelets. So the ITP is a problem of inappropriately low platelet production, but also for those who have ITP, your platelets are being destroyed at a more rapid rate. This leads to a cartoon which I've shown many of you. This is Dr. Newland. He's got muscles, or he used to have muscles. Maybe Dr. Provan's a better example here, but platelets are being made in his bone marrow. They enter his circulation, and then they die after 7 to 10 days. If he gets ITP, antibodies occur, and they start destroying platelets in the spleen and probably a little bit in the liver, and the platelet count drops. For many years, it was thought that the body compensated for this by making more platelets, and this is the old model here, but what's actually happening is your bone marrow, as I said, is being partially suppressed. So you have a problem of destroying too many platelets and not making enough. And this leads to a low platelet count, which causes your ITP. And this leads to things that you all know. The common therapies for ITP are either to affect destruction by making it less or boosting production with different things. And basically we have a list here in the white are things that prevent you from destroying platelets. We can decrease your anti-platelet antibody by things like rituximab. We can take out your spleen. How many have had your spleens removed? Not as many as the old days, but okay. And then we can also try to block these macrophages from shooting up platelets with things like fostamatinib. Or we can, in the orange color here, increase your rate of platelet production by giving you a thrombopoietin receptor agonist. Have any of you been on Ramipilstim, Nplate, Revelade, etc.? Okay, so that's the bigger half of the group here. So these are the current therapies for ITP. The problem with ITP, and coming back to the topic of this brief talk, unmet medical needs, we don't know why the antibody occurs. We don't know whether it's going to go away. We also don't know whether, if it doesn't go away, do you still have ITP? So many people with ITP still have antibody be present. So there are a lot of basic biologic aspects of this reasonably common autoimmune condition we don't know. In addition, we have now taken the terms primary and secondary. We talk about secondary ITP as being this large list. In this pie chart up here, we have things like systemic lupus, also autoimmune diseases, a whole variety of other things which some of you may have, and 20% of people probably have what's called secondary ITP. It's due to something else. But we don't know what that something else is in 80% of the patients with ITP. So coming back to the major unmet medical needs, for all of the patients with ITP, we don't quite have the ability to say it's due to this or this or this. Is it genetic? We don't know if it's genetic. Is it autoimmune? Yeah, it surely is, but what does autoimmune mean? So there's a huge unmet medical need in terms of the basic understanding of this autoimmune condition, as well as a wide variety of others that occur in medicine. So that's the first question mark I'll say. We don't know what causes ITP. Is it due to a viral infection? Is it due to bad genes? Can you blame your parents for this? Can you blame your kids? That's the kind of things we don't know in ITP. The second thing, and Dr. Newland and others are going to talk about pediatric ITP. It's not something I take care of, but we don't know what distinguishes pediatric ITP from adult ITP. And here's a chart about the distribution of ITP. It happens in younger patients, ages 0 to 4 shown up here. And like most things in medicine, I'm going to point over my shoulder here, as you get older, more stuff happens. And so the two major frequencies of ITP are young children and older people. And the two groups of patients differ. Is it a different disease? Kids with pediatric ITP, as you'll hear about, mostly get better within a short period of time. The disease just disappears for many kids. But for most adults, that doesn't happen. Most adults with ITP, the disease tends to linger and sometimes can get worse. So we don't know what the variables are in this condition or in the substrate, the patients young versus old, that regulate whether you have, whether your disease is chronic or acute. So there are a lot of things about predicting who does what in ITP. We can't actually predict which children will become chronic, and we certainly can't predict which adults will go into remission. So there are a lot of unmet needs here in terms of tests or clinical studies or genetic studies will help tell us why the ITP happens and how to predict or prognosticate what's going on in this disease. Which brings us to another thing. Unlike other tests, we don't have a test that tells us you have ITP or not. And it's actually quite interesting at an American plated group meeting about 10 years ago. We had like 400 people in a room, and this lady stands up and describes her ITP that she's had since she was 2 years old, and she had her spleen taken out and lived on steroids for the next 40 years and looked rather Cushingoid and had a lot of side effects of steroids. We were all aghast, and we realized this lady did not have ITP. She had some other genetic condition that causes thrombocytopenia. So there is a subset of patients who have ITP that turns out it's not ITP, it's an immune disorder. It's a genetic disorder with platelets not being made appropriately. So do we have tests for ITP? The answer is no. We have tests for whether you have other medical problems. We have tests for chest x-rays for pneumonia. We have other tests for urinary tract infections. But ITP is a clinical diagnosis. You've got to rely upon your doctors to be somewhat cogent in terms of thinking about what the disease is. It's diagnosed quite simply as a platelet count less than 100,000. It's diagnosed by having no other causes of ITP or thrombocytopenia we can identify. We discussed primary, which is what most people have, versus secondary ITP. It's good for your doctors to think about other causes of thrombocytopenia if you have a low platelet count. Then we've got this lovely staging scheme like oncologists. We've got early stage disease the first 3 months. We've got persistent disease, which is the next 9 months. And then many of you who are here have chronic disease, which means it's been present for over a year. Does it matter whether it's acute or chronic? It may do, but we don't have any basic biology understanding as to why some people have the disease disappear and others it becomes more chronic. So there's a lot of discussion and ambiguity about the diagnosis of the disease. And finally, as I suggest here, have any of you had a bone marrow biopsy? So again, whether that's, I'm not here to shoot your doctors, but it's usually not necessary to make the diagnosis, and in many patients, it doesn't help make a diagnosis, it just gets other things off your radar screen. So it's a test which is sometimes used, but these days is probably not necessary for the majority of patients. So there are antibody tests that you can look at. You can actually measure the antibodies on the surface of platelet and ask who's got those antibodies. Whether those are the antibodies causing the disease or not still remains a little bit unclear, but here the problem is that we in the study we did here, we showed that 22% of patients did not have antibodies. And that still asks the question, well, is it a bad test? So we don't have a bona fide test to predict who's got ITP or a test to prognosticate whether the certain types of antibodies you got, and there are a wide variety of antibodies, are what are causing your disease. Everyone ever have corticosteroids? Sorry, that's said tongue-in-cheek, and I'm not taunting you, but basically the real question comes, do we not have a better therapy, initial therapy for ITP than steroids, which many of you are kept on for months or years? And the answer is we don't yet have better early therapies for this than IVIG or corticosteroids. And this is an algorithm that some of us wrote and published a number of years ago, whereas if you have ITP and if I turn my head to the hiss, I'm going to lose my voice, but basically we usually use corticosteroids for the first 6 to 8 weeks in ITP, and after that, if that doesn't cure your disease or doesn't go away on its own, we will then give you second-line therapy. Those second-line therapies these days commonly, and it depends upon the country and resources, are thrombopoietin receptor agonists, which I think Dr. Prof will talk a bit about later on. If those don't work, or one doesn't work, you can switch to a different one, or to rituximab, or to fostemsavir. These become other therapies, and by the time you get halfway down this algorithm here, about 90% of patients will have a therapy that works. So most people these days have a medical therapy for ITP, and down at the bottom of the line, probably about 5% of patients don't respond to this whole cadre of therapies, and those are patients regarded as being refractory. But again, what predicts whether you're going to become refractory or respond quite well? Again, we don't have an ability to predict who's going to respond and how. So that's another major unmet medical need in terms of predicting whether patient A will do well with drug B. And this is a problem of knowing how to let the punishment, the therapy, fit the crime, which is the ITP. So the other thing that helps us a lot is the ASH guidelines, which Dr. Newland has helped develop, also help us with regard to corticosteroids, saying limit it to the first 6 weeks of therapy and then abandon it and switch to something else. So again, we're protected by recent guidelines that both Dr. Newland and Dr. Prof have headed up in terms of saying don't use lots of steroids. And this is a summary for steroids. Steroids work. About 75% of patients respond to it. The response is sustained in a very small group of patients, many of whom are here. And the bottom line is if you ask patients how bad was it, almost all patients say, I don't want to have it again. And if you talk to doctors, their doctors, only half the doctors say, well, the patient didn't have too much trouble. So it's interesting the difference between the patient's perception of corticosteroids and the doctor's perception. Are there other therapies? This is a list of things which we don't have time to go on, but the early therapy may change in the coming months or years. Drugs such as rituximab or recombinant human thrombopoietin in China or the TPRAs are increasingly being added up front to see if they can lower the use of corticosteroids and possibly provide a longer remission. Other drugs such as mycophenolate, a drug called tacrolimus, there's a whole list of these things which I don't have time to go into, and hopefully Drew will be able to mention some of these. Are they available? So if you look at rituximab, does adding rituximab up front help? It might help a little bit, but it doesn't really change the course of the disease. What about TPO receptor agonists? This is a Chinese study with L-trombopeg added to dexamethasone, and what they showed is by week 12 in newly diagnosed patients, 80-some% had a terrific response, and half those patients didn't require subsequent therapy. So there may be some benefit of adding a TPO-RA at the initial diagnosis. This is being studied in a couple clinical trials. As you know, a very lovely study done in the UK with the drug mycophenolate, and if you look at the blue curves versus the pink curves, those that got mycophenolate in the blue and adding mycophenolate early in the disease tend to give you a better and higher platelet count going forward. But there are side effects of mycophenolate that some of you who might have participated in this study have had as a complication. And there's a couple of studies ongoing right now looking at whether adding new therapies, such as drugs like analimumab, which is I'm going to be derogatory to the company, like a fancy rituximab, whether giving this up front makes a difference. We're trying to see if we can change the course of the disease by altering upfront therapy. We don't have an answer just yet if that can be done. As I said before, we don't have an ability to predict who's going to become chronic. Now, why is that important? Our chairman, Professor Newland, here did a lovely study taking newly diagnosed patients and giving them the drug romipilstim called Nplate. And what he showed is by 1 year, about a third of patients, their disease disappeared. So if you just do nothing except support platelet counts for a year, a third of all patients will remit who are adults. I'm not talking about kids, but adults here. So I think right now there is an inability to know whether this 1/3 of all patients, can we predict who that's going to be? Because if we can, then we'll just say, hey, tough it out for a year and your ITP will disappear. We don't have the ability to know who those patients are and how to define them. This is an old topic, but we also can't predict who's going to respond to splenectomy. As you may recall, there are splenic scans that have been done. Did any of you have spleen scans before you had your spleen taken out? I mean, it's available in the UK, it's available in one center in Australia, it's not available in the United States, but whether that helps us or not, probably is a moot point these days, because I think our general trend is not to take spleens out anymore, and we can also thank, and this is the rate of splenectomy in North America declining astronomically, and to be honest with you, I will share Dr. Newland's aversion to spleen. I haven't taken out a spleen in 25 years. So I think right now this is a old point, but I'm simply saying that it's still a therapy for some patients. It's commonly done in other countries. And the current guidelines that Dr. Newland and Dr. Prof have written basically say if you can afford it and can maintain a patient medically, avoid splenectomy at least for a year. And in my hands, I would say if I can, I will avoid it almost completely. Here's a sensitive topic, and I'll use this in the last couple of minutes, which is to say there's a lot of other stuff that happens in ITP that we don't talk about that's part of the disease, and I think many of you know about this. First of all, ITP is a bleeding disorder, but it's also a clotting disorder. And this is a study, if you look at the far left, the two bars, this looks at patients who have ITP versus those who don't and ask, what's the rate of having a clotting disease called a DVT? And that hazard ratio, the risk is about 2.5-fold higher if you have ITP than if you don't have ITP. And again, have any of you had blood clots? Oh, good. So it's a small group. It happens, and it's a complication of the disease, I think. We can't predict how or why this happens. This is another, I think, major unmet medical need in ITP. Quality of life is an interesting discussion. Any of you fatigued? Yeah, me too, but I'm jet lagged. But and I say it not to be derisive. It's just basically that fatigue is a major component of ITP. Quality of life issues are ubiquitous, and we don't know what causes fatigue. We don't know why some people are totally happy at a platelet count of 4,000, and others can't go to work and want to stay in bed all day long. Something new in ITP, which is cognitive function. We've done some studies, as Dr. Kuter here, looking at cognitive function ITP, and actually it's reduced in some patients. And half of patients with ITP, and this is the left three bars up here, these are cognitive function tests that show that cognitive function in some domains, and we probably should apply this to politicians, but that's a different story. But basically, cognitive function is decreased in about half of ITP patients. Again, don't know the mechanism. And Cindy, maybe I'm wrong about this. It probably is not due to infarctions from low platelet counts, but that's a discussion. We don't quite know why cognitive dysfunction occurs. There's a large study that Dr. Kuter and I are participating on to try to identify why this happens in patients. Here's a more sensitive topic, and pay attention to the blue lines, not the red lines. The blue lines look at who lives and who dies, and I'm not here to make this a depressing conversation, but in the dotted blue line, that's the normal age-related control population that don't have ITP, but the patient ITP have a slightly reduced survival in several studies that have been done. We're about to publish another study in a couple of weeks that actually shows that what's called hazard ratio risk of having a fatal event is slightly higher in ITP patients than those who don't. Why that's the case, I can't tell you. But we do have some data which I'll show you next. And I apologize for a busy slide. This is fresh off the press as of this morning, by the way. In the green are what happens to ITP patients in a large population study we have just completed in the United States, looking at 180 million people, collecting all those with ITP in that group and asking what happens. And basically, there is if you look at what's called the rate ratio up here on the far right, it tells you that if you have ITP, you have a 1.57-fold greater risk of having a malignancy. It's not breast cancer. It's not lung cancer. It's not GI malignancy. It's what's called a hematologic malignancy, such as a low-grade lymphoma. This is a slightly higher risk than in patients who don't have ITP. If you go further down the line, looking at what are called autoimmune conditions, if you look at who develops autoimmune conditions, again, there's about a 4-fold greater risk of developing lupus or things like that in patients with ITP. And again, we don't know why this happens. We don't know whether that's just disease that was there all along and has been hidden, but there are undercurrents of other disorders in ITP that have a tendency to emerge over time. Why this is happening, we don't know. How often it's happening, we don't know. How we can predict it, we don't know. But these are the variables that I would consider as unmet needs in ITP. Finally, and I'm going to end on this, we can't yet cure ITP. And I'm going to say there's a lot of data on this right now, and I'm simply going to skip ahead because Dr. Prof will talk about this, and that's that there's a huge amount of new therapies in ITP. This is a long list, which I'm not going to go through, but there's a huge number of new therapies being developed whose intent is not to make the platelet count just higher, but to make the disease disappear. So we've gone from taking the spleen out in 1916 to giving a lethal dose of steroids to get your counts up, to using a TPRA to keep your counts up, and now we're thinking about whether we can actually cure the underlying disease by changing the immune system, and these are new therapies under development. What we really need is this, which is a blood purifier, which is available in 1880 in Canada and Halifax. On that, I'll thank you and be happy to take any questions if there's time, Mervyn.
We've got time for one or two questions, if anyone would like to ask. You'll also be able to explore them in the next session as well. And what I was going to say was that these talks are being recorded. They will be available on our YouTube channel afterwards at some stage. It was interesting, as you know, I have a bee in my bonnet about splenectomy. And I find it interesting, and I see this get this question from quite a number of patients who get it from their physicians. And it's often physicians who don't have a real experience of ITP, who say, well, you've tried everything and they don't work, we'll take your spleen out and that'll be fine. Holding a splenectomy up as the be-all and end-all. And of course, if you look after patients with ITP all the time, you know that if you fail everything else, you're going to fail splenectomy, but you're left in a worse position.
Yeah. I think my own cynical view of this is that you're creating a new disease to create another disease. So asplenia in many patients is as bad as having ITP and sometimes worse from a life and death point of view. So if you see one overwhelming pneumococcal infection in a splenectomized patient, you're never going to do it again.
Yeah.
So
those who develop hematologic malignancy later on, assuming that was the way back beginning, so what level of primary ITP before?
And Dr. Proven is bringing up an interesting topic in ITP, which is, we find that as time goes by in observing population ITP, the other diseases emerge. They are probably there all along, and many people, I think, who have primary ITP probably have some underlying disease we just didn't diagnose up front.
There's a question at the back.
Yes, Dr. Kuter, Professor Newland. Just a quick thoughts on the destruction of platelets. Obviously, we know that the spleen can be the location of that process. What about other parts of the body that might be involved in the destruction of platelets for wider organs? Can you eliminate that side of things?
I think I heard half the question, but I think you're asking whether is the spleen the only place platelets are destroyed? The answer is no. There's great evidence they're destroyed in the liver, and we don't take out livers. There's probably good evidence that are also being destroyed in animal models in the lung, but any place you've got a macrophage, which is the chewing cells, and by the way, a third of your liver is macrophages. So basically, I think there are a lot of folks, we tend to ignore the spleen as the major site of autoimmune destruction of cell types. There's a thing called a Kupffer cell in the liver that does this.
Okay, we'll move on now, because obviously there'll be a few minutes in moving to various rooms. Mervyn, do you want to tell people where to go, as I clearly don't know?
Okay, for the breakout sessions, the adult breakout session with Professor David Kuter and Dr. Gerard Crotty, medical advisor from Ireland, will be in this room here. So if you want the adult breakout session, stay in this room. The paediatric ITP session with Dr. Rachel Grace, who many of you will know. Rachel has been the author of articles for a platelet journal over the last few years. She's from Boston Children's Hospital in the USA. Rachel will be joined by another medical advisor of ours, a friend from Manchester Royal Infirmary, Dr. John Granger. That will be in the Charles Halley room, and there will be people to guide you to that room as well. And the women's ITP will be with Dr. Cindy Nuna. Again, Cindy is another author of the platelet articles. Cindy's from the Columbia University Medical Center in the USA, and she'll be joined by another medical advisor of ours from Glasgow Royal Infirmary, Dr. Catherine Baggott, and that will be in the green room. And again, there'll be people to actually guide you. So thank you very much. So if you just want to go to your rooms, then at 11:15 we will have a break until 11:40, and then we'll be back in this room. Thank you.